Yeah, Trini sent me an
Call to order the Health and Human Services Oversight Committee, and while I thank those who scheduled us here, it's going to be very difficult not to look out the window at such a beautiful day, so we will move right along. The clerk, the acting clerk would like to know if it's okay with everybody, that he records the meeting so he can take notes off of that. Otherwise, we cannot guarantee you being misquoted. I'm going to take that as a yes with a subtle threat.
Thank you, Mr. Chair.
Would the clerk please call the roll?
Representative Mark Pearson,
Here.
Representative Bill King, absent. Representative Weber,
here.
Representative Murphy, Representative McDonald,
Here.
Representative Edwards, absent. Senator Gray, Senator Rosenwald,
Here.
and Senator Avard. We have a quorum.
Thank you. And we have before us the minutes from our last meeting, which was February 23rd. I'm sure we've all had a chance to look over it. Motion to approve made by Representative McDonald. A second? A second. A second by Representative Weber.
The second time.
Two's good. All in favor?
Aye.
Aye.
Opposed? Thank you. Senator Rosenwald
Abstained.
abstains because she wasn't here. It could be argued you found no errors, but
No runs.
I
no-
understand.
No errors. Nobody left on base.
right. Commissioner's update and pinch hitting would be, I'm trying to get the title right, Deputy Associate Commissioner Trish Tilley.
Good morning. Thank you all for inviting me up here today. As you said, I am pinch hitting for the commissioner this morning. It is a beautiful week to have spring break. I have just returned from my own, so I'm a little tan and happy and probably blissfully unaware of what's exactly going on. So what I'm going to do, if you, with your indulgence today, is just spend a few minutes talking about our state health improvement plan, which is something that I can rattle off the top of my head. As many of you know, first of all, you have a copy of the outline of it in front of you. As many of you know, our state health assessment, our state health improvement plan, we affectionately call those the SHA and the SHIP, are developed every 5 to 7 years. They describe sort of a broad array of the issues that impact the health of people in New Hampshire. The purpose we've had of developing this plan is to create a place where everyone lives through, a place where everyone lives well through some coordinated resources, coordinated planning, and coordinated action across many different sectors. Most importantly, for you to know, this is not just the department's plan. This really is a plan to help all of our partners across the state towards achieving some of our common goals. The SHA and the SHIP is built by a state health improvement Plan Advisory Council that was established by legislation back in 2020. It's RSA 126A 87. And the council itself is made up of a cast of thousands. There are over 40 individuals that are on the council, and it reflects community partners, state agencies, legislators, policymakers, really everyone who has any interest in the health and well-being of the state of New Hampshire. And that's important for you to note as you skim through it, because there are things here that are well out of the four corners of the Department of Health and Human Services. There are things in here that we don't necessarily touch. We certainly have some interest in. And so it's important to think of that again, this is not the department's plan, but really is the state's plan. Every state has a state health improvement plan to some degree, but what I am most proud of in this particular document is that New Hampshire has moved beyond essentially what has always been a list of top 10 things that kill you. You know, you would get a plan and it would be tobacco, substance use. You could sort of, in fact, all of you could write it down off the top of your head, what you would typically see. With the help of the council that has been working on this, we really went beyond that and really tried to look at in a much more holistic way around four broad areas. We looked at access to opportunity, community, health status and outcomes, as well as social connectedness. And so the issues and the goals and objectives, again, bigger than DHHS. And you're going to see themes in there that all of us talk about regularly and where we often have broad common ground, even though there might be different approaches to getting to the same end. So things around housing, access to good jobs, making kids and families have enough to eat. You know, in the access to opportunity section, the council elevated ideas around removing barriers, limiting access to safe, affordable, disaster resilient shelter, i.e. housing. Issues around infrastructure and programs that promote financial independence. Again, making sure people have access to good jobs in their communities. Expanding efforts to improve nutrition. Again, making sure kids and families have things to eat. We can get there in a variety of different ways, and we have appreciated the legislative support in helping us over the past few years in all of those areas. In the community section, you'll see everything from addressing environmental health concerns to ensuring we have opportunities for every community for lifelong learning from early childhood to adult learning. We're looking at, again, reducing exposure to environmental contaminants, everything from PFAS to lead exposure, testing water. We all know that given the news we've had right now about the importance of our environmental health risks in the state of New Hampshire. We've elevated reducing geographic barriers that limit individuals' abilities to access preferred resources. So again, that's around the built environment, making sure that we've got safe places where you can travel, you can bike, you can walk, and that you have the transportation that you need to get to the places that you want to go. We're looking at the support for supporting caregivers and making sure that they are connected within their community and expanding programming for lifelong learning and enrichment. As we move to health status and outcomes section, this is a little bit more, you know, what has been the in the wheelhouse of public health in the past. You'll see that we've shared many of the goals that you have had over the past few sessions, including expanding access to affordable care for dental services and behavioral health. You'll see a notice here to closed loop referral. We've all known that that's been in the news, and we're thankful right now for this group's help in helping us get to a final closed loop referral contract that was just passed by governor and council. So it's a place where both our outside partners said this is something that's really important, and we wanted to make sure that we provided some thank you and some gratitude to you all for helping us get there at the end of the day. Also, items in the health status are, again, the pieces that you would expect around workforce. We're going to hear some stuff from Danielle today around workforce. We're going to make sure that we have access to a continuum of care for behavioral health resources, including improving quality prenatal care, labor and delivery services, and postpartum care. You're going to hear a little bit later from our folks in maternal child health around newborn screening. All of these things are connected. So while I can talk about these health outcomes all day long, I will spare you of that. The thing that I am most proud of in this particular plan was long before our Surgeon General released his recommendations on combating loneliness and social isolation. The Shawship Council deeply understood that loneliness and isolation is much more than just a bad feeling, that it really harms both individual health and our population's health. And as the Surgeon General also remarked after we published ours, social isolation is associated with a greater risk of things like cardiovascular disease, dementia, stroke, depression, anxiety, and premature death. The mortality impact of being socially disconnected is similar to smoking 15 cigarettes a day. And even greater, there are even greater associations than with obesity and physical inactivity. The consequences of a lack of social connection fuels our substance misuse issues in the state, as well as our youth mental health crisis. So state government doesn't always play the lead role in addressing some of these issues. There are things that communities, faith-based organizations, others may need to take on, but I think we all have a unique role to play when we think about strengthening systems for things like aging in place or supporting stronger connections among young families. So, if the department isn't the lead on this great plan for every single thing, what have we committed to doing? Across public health and across the department, we have jointly begun some intense planning around 6 main areas. One, reducing heart disease. It's still the leading killer of the state of New Hampshire. It's not particularly sexy. We don't talk about it a lot, but heart disease is still a #1 killer. And so we really need to be thinking in more preventative ways to address creating opportunities so that we address premature death associated with heart disease. We are looking at improving the health of mothers during and after pregnancy. Again, in many of your committees, you have heard us talk about the opportunities that we have to strengthen a system for labor and delivery and prenatal care, especially given the challenges that we have around workforce in this state. We would be remiss without talking about improving youth mental health, from prevention to providing acute residential care. It's what we talk about every day in the news, in WMUR. It is what guides much of our work these days, is around ensuring that we have a much more robust system from soup to nuts for youth mental health services. Of course, the department has prioritized addressing the harms of substance misuse. And so that is not only, our services from the doorways and ensuring that we have that kind of robust care involved, but also ensuring that we have preventative services in place so that we never get down that path in the first place. It also means addressing some of the other harms of substance misuse, which lead to premature death, which is, of course, not only important overdose, but things like infectious diseases or heart disease that's related from many years of substance misuse. So those are things that our department is taking on as priorities. Decreasing the spread of sexually transmitted diseases. I don't think I can't get away without saying things like chlamydia, in front of you at some point or another, but that's something that we're continuing to address within the department. And then finally, reducing exposure to environmental hazards. We've all heard the impact right now of PFAS. We know that our partners at the Department of Environmental Services are working closely around PFAS in water supplies. We're working hand in hand with them. And then down to the everyday environmental hazards that we continue to still struggle with, the things like lead exposure among children. Those are things that are really important to us. We're really promoting issues around water testing and ensuring that kiddos have the appropriate screening at ages 1 and 2. So we do not have a specific ask of you today, but we wanted to be able to provide this to you to ask you to consider as you wrap up this current session, as we think about the next biennium, how can we ensure that communities have the resources and the policies to address these priorities? We also, again, wanted to thank you for the help that you have given us and the guidance you have given us in order to advance many of these activities. I think we are on the same page in many of these areas, from issues such as the expansion of Medicaid, postpartum, adult dental, investments that the legislature has made in housing, around behavioral health, substance misuse, the planning we have done for healthy aging. You have helped us in everything with policymaking regarding PFAS to lead poisoning. There are a number of ways that smart policies, investments strengthen our states and help our residents have some better opportunities. We know that money is going to get tight in the next biennium, and I think we're all going to have to think very strategically about where we continue to support policies and investments so that we can make progress on these broad areas of health improvement. So that's the ship in, I'm happy to answer more questions around it, but we're really excited about it. We are very grateful for the team on the Shaw Ship Advisory Council, again, from all across the state, who have helped advance these ideas. And we are very committed to digging in, especially in those 6 areas that I mentioned, in improving the work through the department. So thank you.
Any questions? Senator Rosenwald, welcome
Thank
back.
you. I have two separate questions, if I could. Could you catch us up on closed loop? Because the last I knew, the executive council had tabled the contract.
It was passed at the last executive council session.
Okay, so they took it off.
Yep, they took it off the table and passed.
Okay. And secondly, there's a proposal in Nashua to build an asphalt plant in the middle of a low-income neighborhood of housing. And DES is in the process of evaluating the application for a permit. Their regulations require them to look at the public health statutes in doing that. But when I asked them if they were considering things like asthma rates in children, they kind of looked at me like they didn't know what I was talking about. So my question is DHHS speaking to DES about this application, or are they just working by themselves?
So we have a very close relationship. One of the benefits of public health sitting over at Hazen Drive is we're physically in the same building as DES. So we have a great relationship with them. I don't know the details on that particular proposal, but I can go back and check in. Commissioner Scott has been a great partner to us and has always welcomed public health's participation in some of those processes. They have their own, policies that they follow, but they're always have welcomed us to participate.
That would be great because they are citing the public health statutes.
Great. Thank you.
Representative Murphy.
Thank you, Mr. Chairman, and thank you for taking my question. I can't help but notice with your health improvement plan, access to opportunities, social connectedness, community, et cetera, which is great. My question is, do you have or are the community health, workers part of your plan going forward? Because obviously they're relatively new, but they're becoming increasingly apparent to us that they may be part of the fabric of healthcare in its delivery and the social determinants of health, et cetera, in the community. So are they part of your plan?
Absolutely. So thank you. So CHWs or community health workers are incredibly important member of sort of the team of healthcare providers or other, individuals within our community that can address some of those social determinant needs, can really develop relationships with families who are in need and get them connected to the right services. And so we've thought about them a lot in this plan. And when you think about things like social connectedness, they're really sort of the key people to make sure that folks that you know and trust in your community can connect you to the resources that you may need. We've been thankful that there's been some work this session around CHWs, and we thank you for through workforce bill. And we have also been able to use some federal resources to ensure that we can continue funding, at least for the short term, community health workers in our family resource centers, in our federally qualified health centers, and in our local health departments. So absolutely. I am a huge fan. In fact, I will be speaking at the Community Health Worker conference that is occurring next week, to which you're all invited to come.
Representative Merchant.
Thank you, Mr. Chair. Can you follow up on the community health worker in regard to the advocate in regards to certification, the need for it? Because we recently had a bill in the House and I sort of misunderstood it. So could you provide some clarification on the certification, what it does from not just the person's competency, but what it does financially as far as being able to bill for it?
Sure. I could Henry could probably speak even a little bit better to this, but so currently we don't have a system for certification for community health workers in the state. And so we have had to pay for them through things like grant funding because we've not, without that level of certification, we're not able to bill Medicaid. So we have a couple of different ways, opportunities to explore how we could or could not do that moving forward, how we could partner with the Office of Professional Licensure and Certification. And there are a number of different ways that other states have thread this needle. And so we're looking for the next year or so to figure out what's the best way for New Hampshire.
Thank you.
Representative McDonald.
Thank you, Mr. Chairman, and thank you for this report. It's very comprehensive and very well put together. On page 5, talking about where can we begin to address inequity in New Hampshire, it talks about Sullivan County and how more than 30% of their monthly income on housing is spent on, and it's above the state average. I'm surprised is that the only county in New Hampshire that's true of? Because I would think a lot of the southern counties, that would be even more so a problem.
I think this is an artifact of the lower incomes in Sullivan County and the higher housing costs. So you sort of put those two things together and you end up spending a larger proportion of your salary. So places like Hillsborough and Rockingham, while the housing costs are astronomical, sometimes there's a little bit of a income bump that you might get in those communities that you don't see in places like Claremont or Newport. And certainly Representative Merchant could speak to that.
Could I have a follow-up?
Follow up.
So it is unique. It is a unique situation, particularly
Yeah.
the Sullivan County.
And again, you could look at a place like Coas. Coas hasn't had the same housing costs rate, even though their salaries are a bit more depressed than the rest of the state. Their housing costs haven't quite gone up as high. This data is a little bit old. We put this together in our state health assessment in 2022. We can look at that data again moving forward. But at the point in time, Sullivan really jumped off the page.
Thank you.
On page 1 on the far left, thank you so much for that about First Nations peoples. But I notice when I look at the left column on pages 5, 6, and 7, while blacks are mentioned, Hispanics are mentioned, various counties and so on, there's nothing about this population. I'd like to see more.
I think that's great. We would as well. One of the statistical problems we have is the relative small number of American Indians that are in New Hampshire that are in the data sets that we have that are identified as American Indians. So sometimes we have to aggregate years of data. And so it makes it hard and masks some of those disparities that we certainly know exist throughout the rest of the country.
Could you give a guess as to how many individuals?
I could not give that off the top of my head. I am sorry.
And then were you to try, people marry other people.
Yes.
And so one might claim, oh, sure, I am 1/3. And so it counts, but it's different from 2/3.
Yes.
I'd like to see data coming forward when you can.
Yes, we would as well. Of course, not having a federally recognized tribe in New Hampshire makes some of that difficult as all. We're one of the only states that does not have a federally recognized tribe. Again, makes it complicated with our data sources where we can accurately capture. As with most data sources, people self-identify. So if someone says they are, we have no reason to believe that they are not whatever it is they say they identify as.
So perhaps for statistics purposes, the fact there is no federally recognized tribe is not that important because an individual can claim a membership even if the feds don't recognize it.
Correct.
Okay.
But we also don't have a population center. We don't have a federally recognized tribe or a place where that you would have a larger proportion of folks who identify as American Indian living or indigenous populations.
Okay.
All very complicated. That doesn't what it still supports, however, is we know that American Indians have far worse health outcomes than many other groups.
Sure. Thank you.
Yep.
Any other questions? Representative Merchant.
Thank you, Mr. Chair. Going back to Senator Rosenwald talking about the issue in Nashua in public health, we have something comparable to that in Claremont. They're trying to use a transfer station to make it into a dumping station, quite frankly. So how can I work with the department on the public health issue as well as working with DES, because that location is within 1,000 feet from a elementary school, along with the residential, and we have deep concerns of what it's going to do from a public health point of view, but we don't know exactly where to go.
Sure. So I would encourage you to reach out to us, reach out to me directly, and I can connect us with the right folks over at DES. We do a really nice job of working in partnership. We do not have public health authority. They would have the authority in that space, but as I've said, they've really welcomed our feedback as they go through their policies and processes for approval.
Representative Weber.
As of the 2020 census, 1.1% of the New Hampshire population self-identified as American Indian and Alaska Native alone. 1.1%. And there is a category of 2 or more races, which is 10.2, but it doesn't say what the mix is.
Thank you.
Thank you. Anyone else? Thank you so much.
Thank you.
And the chair recognizes, we all recognize Mr. Henry Lippman.
Good morning. Thank you for the chance to share a few things. The first item I'd like to share is the report that's statutorily required from HB2 with respect to a couple of components of what the department was asked to do in that legislation. One was to, and you
What's
have,
it look like? Because we got a stack of them
it's a one page, two-sided
with
document.
yellow on the back.
You have the yellow on the back.
Got it. Thank
The
you.
yellow's actually the punchline, I think. If
I promise not to read ahead of
That's
you.
okay. So we were asked to apply for a state plan amendment to add postpartum coverage, which meant going from 60 days to a year. And we were among, every state has subsequently adopted that aspect. And we were supposed to do it by a date in August, which we met that deadline. We stood it up on October 1st, and the number of women that have been able to take advantage of it in the period from October 1 till the end of March were 137 women. I need to sort of go back and compare that to what we expected, but I think it's on the lower end of our expectations. That being said, I still think it's kind of early. We'll continue to see that grow, and then our goal is to start to add some metrics once we have some credibility and experience. But this was the first metric I could bring to you, and intend to bring more. In terms of the third paragraph on the second page, had to look at what we were doing in terms of expanding the access to the, really going back to the future, back to what was in place before 2011. We've made the rule changes and such to do that. I need to collect some utilization data on that to give you some sense of that, and I think on the next report I'll be able to do that.
Representative Weber.
I'm recalling a news report recently about our birth rate having declined to its lowest level in living memory, or maybe any memory. And are the lower numbers in line with that, or would you know?
So
Or
actually,
are they even lower than you would have expected, giving a declining birth rate?
my recollection in for the 22 data is actually that New Hampshire was one of the only states that showed an increase in
Really?
the birth rate.
Okay, so
think
maybe that was a national story and I misunderstood. I'm sorry.
And so I don't really have a feel for this year, but I think that at least in the Medicaid side, I'm seeing fairly stable. And we have done things to try to support hospitals being able to, and doctors. Part of HB2 was allowed us to target a rate increase for people who deliver babies, also the freestanding birthing centers. And the prior year, we had increased the reimbursement to hospitals for doing births. I think it was 34% for the small hospitals and 24% for the larger hospitals to, try to stabilize what's going on in terms of the subsidy that Medicaid may do. I know not to sort of weigh into sort of the bills that are currently active, but one bill of concern to me as the Medicaid director is the one that deals with loss of consortium, which I know isn't in front of this committee, but the concern is that particularly for obstetrical services, the malpractice market has hardened, and particularly for nurse midwives, and concerned about if there's an impact on, if that legislation were to pass, what's the impact on rates, and in terms of does that have some unintended consequence, at least on the access side.
Senator Rosenwald.
Thank you. So, Henry, are these 137 people, were they eligible because they were not eligible for Medicaid expansion, but were eligible under that 250% of poverty, I think it is, for the pregnant women?
Yes.
And might some of them have become eligible for Medicaid in a different way, let's say expansion, and so there are maybe actually more than 137 women?
Right. I think you're hitting on a point. It's in terms of trying to predict this, in terms of where people land on eligibility is affected by a lot of factors. And, with the economy, with wages going up and different things, that people may land in different categories, or what we're seeing in Medicaid expansion, as an example, it hasn't come down as much as we thought it would. It's come down a lot, from like almost 97,000 to 59,000. But I think that it just may be and I'll have to look into it more. I think it's a fair question in terms of, where people are landing when they give birth, and are they getting the 12 months of coverage. So I think there's more to look into there, and I just didn't have enough time to do more than this for this month's report.
Thank you.
Any further questions for Mr. Lipman? None for the moment, but we may bring you back at the end if this
I do
time.
have two more reports to.
Well, thank you for what you've done, and please
Okay.
go on to the next two.
Sure. And Dr. Finney also has a report too to share on give you a dental update.
Good.
We're actually celebrated the 1-year anniversary of dental, the beginning of April 1st, marked starting our second year. Hard to believe, isn't it? The report I wanted to go over is this one, the bright orange. And just wanted to share, I'm going to jump to slide 3, and there are slide numbers on these this month. On the bottom right-hand side, just wanted to give you some comparative information that was compiled by CMS in terms of New Hampshire compared to other New England states on the unwind and the United States. And I'd like to point out a couple of statistics here for you. Probably 4 to the right is the percent renewed on an ex parte basis, meaning that the department had enough information to not require the person to fill out a new application, particularly. What we're seeing there is that, we've seen a significant improvement in this area in terms of being able to renew. We had the 4th highest ex parte rate in the nation. We began in the unwind. We were under 20% in our first number of months. It does depend on the type of population that you're also unwinding or reconsidering. So we've made a lot of progress there in helping people who are eligible maintain coverage. The other thing on the far right would be the percent pending at the end of the month. Basically, we hear a lot of things about how New Hampshire, sometimes the eligibility processing isn't as fast as we like, but in terms of backlog compared to other states. I think, while we have areas to improve, I'm not going to say that we don't. But, on a relative basis, we were second in New England and well below the national average. And also, and the month that we're looking at, that page 3, is January, which is the latest published information. And then the percent that lost coverage is going back towards the left is there's a column called number terminated from Medicaid and the percent terminated. We had 518 individuals out of 8,924 that didn't maintain coverage, which was almost a 91% renewal rate. And again, in terms of where we are in the unwind, we're at the part of the unwind where we're dealing with CFI and nursing home, which we expected would be much higher retention. And the next page, page 4, is just the month of December, a preceding month, just for comparison. So I feel like, again, there's always room to improve, but we're doing a pretty good job comparatively. On slide 5 is the ex parte renewal rates, and there you can see, when we started the unwind, again, in part based on the population we're unwinding, we had a low of 18%, and we hit a high of 81% in the first quarter of 23 federal fiscal year, I guess that would be, and saw an increase from 76 to 81 to 79. That's when we're hitting the most vulnerable populations. And again, typically once you're in a nursing home and under Medicaid or in CFI or other waiver populations, you're going to see people not churn as much. The next page 6 and 7 are kind of the enrollment numbers. The page 6 at the top gives you the statistic as of basically the end of March, which is the 1 year mark, right? We had 182,753 people enrolled in total in the program. That's down from a high of 251,000 plus individuals. But at the bottom, you can see, if you look at the last line on the page, the grand total. The week that things sort of shut down during the public health emergency, we were at 177,420. At the end of March, we were at 182,753. And what we see in the next slide, just during the month, we see fluctuations. Typically in the middle of the month, we'll see a higher number of individuals. So as of the 22nd, we had 184,000 people enrolled in the program. But again, when we finish going through renewal activity, it'll probably come closer to 183,000 will be probably where we likely will end the month of April. The next page, page 8, is I think something I think is probably the most valuable of these next slides, the slides that I've covered about what's going on in enrollment. On November 6th was the low point in the unwind in terms of enrollment. And you can see, a couple of groups that we've been worried about. The purple line, I know it may not be perfectly easy to see, but the purple line and the yellow line are children, and we've seen that increase by, almost a little over 3,000 children have come onto the Medicaid program. There was a concern. New Hampshire was, highlighted as being a state that lost a lot of children. That part of it is we've seen, I think last time I presented to you, we've had family income. We've had a higher proportion of our families be in the 300 and 400%. We only go up to 323, which is among the highest, meaning the most favorable eligibility opportunities. We've seen school enrollment go down. But what I think we're seeing play out here is the continuous coverage. Children are now given 12 months of continuous coverage. That was a requirement not just in New Hampshire, but across the country. Also in the Other categories, not so much big, and Medicaid expansion has seen an increase as well, from the low point, but again, we're down from almost 97,000 individuals. What I think is going on a little bit there, we need to do a little bit more research, is a lot of people looking to that eligibility group when they're waiting for other determinations, other benefits to come into play, like if they're waiting for disability determination or other things. This is a way they can get coverage until maybe a waiver is considered. But you know, in terms of the entire program, the mix is shifted a little bit more towards Medicaid expansion, the Granted Advantage program, which, you know, has the higher federal match. But I think this is, you know, this is a graph I think I get a lot of information out of. And then page 9 is really our detailed report that we look at in terms of, on a monthly basis, in terms of closures. And here we're looking at both people who are protected in the continuous coverage as well as individuals who are just regular renewals. And as sort of supported by the ex parte rate, we had 91.6% of the regular renewals retain coverage, and 88.5% of the protected population. You can see the protected population is down to the very little. There was only 29 protected people that went through, and we expect to have run through all the protected people by the month of May. And we did slow down with the most vulnerable, and I'm glad we did, based on some of the challenges we're seeing, and I'll get to that a little bit more in a moment. Page 10 is just totals up all the activity by every month. Page 11 and 12 are focusing on an area that I haven't reported on before, and this is a dashboard that we're looking to further develop, but this is a month by month look. The waiver population was given additional protections in terms of the medical evaluation assessment that has to be done on an annual basis. People did not have to complete this during the continuous coverage period. So there's some people that have not had that checked for almost 4 years. And so we're going through that process here. The yellow highlight is the number of MEAs that we're looking at. And you can, it's not until page 12 where you see in the month of March and looking at February, where we start to see some closures around. You know, we've had 66 closures on almost 1,200 medical evaluations, but the department's been using a number of different strategies to try to get these evaluations done, give people an opportunity to appeal. We've asked CMS to extend from 15 days to 30 days the opportunity to appeal and maintain coverage, because I think the populations in this group, you know, maybe have a lower capacity to respond quickly, and so trying to give them more time. We're waiting for that approval. We did also ask for another temporary authority on the income verification side of people in nursing facilities are allowed up to $2,500 of assets. In terms of asset verification, is to try to move things along a little bit faster, as if everything else lines up and they have, you know, $2,500 or less in assets, we're not requiring them to verify that $2,500, which helps move things along a little bit faster. We'll probably have more to say about some other things that we're looking at this place. This is, you know, the population we're most concerned about, the people that are home alone and, you know, depend on their services that they get. Then just pull a couple of slides that really go back to sort of financial eligibility, and the darkest color there on page 13 was the month of March. And you can see that here, just there were 342 individuals that we processed in the CFI basis, or at least on a financial eligibility basis. All but 5 made it through the financial standpoint, and that the ability, of the ones that were more than 2/3 of them ended up being able to be ex parte review, which is sort of the bottom right hand corner. There were on the left hand corner, there's a little chart in terms of the 5 people. One was for income, one was failed to do the redetermination, and 3 may have been for other reasons, such as they moved or that there other change in circumstance, change in household composition, that things like that. And then the next page, 14, is just looking at those numbers on a percentage basis. Then on page 15 is looking at the nursing facilities. Here on the top left, there were 278 individuals in the month of March. All but 4 made it through the financial redetermination process. Again, on the bottom right, a high level of passive ex parte renewal. And then on the bottom left, there's 1 person on income and 3 for other reasons. And then page 16 is just the percentages for those same numbers. Page 17 is sort of where CFI eligibles are. The CFI case managers asked us to sort of lift this up a little bit more. We have seen a decline in the CFI population. We do want to see that go in the opposite direction, because when you compare the cost to the state to keep people in their homes versus an institution, in most cases, it's considerably less. As you may also remember, the system of care that was included in, I believe, HB2 as well. The department was asked to apply for a waiver to implement presumptive eligibility for the CFI population. Again, there we met our deadline in terms of submitting as part of our 1115 waiver to include that. All indications are right now that we expect that we'll get that approval by the end of June. It will take us a little time to stand it up system-wise, but that's going to help, I think, there. And I think, I think we have every reason to want the CFI population relative to other populations to increase. Take any questions you have on this.
Representative Merchant.
Thank you, Mr. Chair. As always, Mr. Libin, I want to say thank you for your due diligence, the work you put into it. We state benefits immensely from it, and I want to say publicly to thank you. In regards to the CFI, is there, what I'm trying to get to, some sort of comparison to the waivers that are hopefully growing compared to nursing home, at least the county nursing homes? Because if I understand it correct, financially, it's better probably for the state financially as well as for the patient psychologically and otherwise to probably age in place. Is there any kind of comparative numbers in looking at nursing home occupancy versus the use of CFIs?
Yes, I think that's probably a good thing to maybe have a longer discussion and prepare some information for you. But, I think the department would say is that, as we compare to other states, our reliance on institutionalization versus home, the HB2 rate increases, we had Waypoint, I believe, came in and met with the department talking about what a big difference that's made in terms of they're able to increase the number of people they're serving and the number of hours. So I think part of our CFI problem has been the rate side of it, that it was hard to hire workers to do the in-home care. But I know that they took the initiative to come in and talk to us. Appreciation for what was done by the legislature to improve those kind of rates. I think, sometimes we can be, it's worth making the investment in the, the home care side more than we have. I think seems like we're spending more money in the long run, though we're really not.
Follow up. Follow up?
Nope. Thank you.
No? Senator Rosenwald.
Thank you. Henry, I love data. This is great. I have two questions. On slide 6, I think it is. Maybe it's
7.
6 or 7.
Yes.
We're showing a decrease versus pre-pandemic among individuals with disabilities. And that's concerning to me. Could you talk more about why those three distinct populations have a lower caseload?
Yeah, I think the children's with disabilities is one we did a little research into, and part of that is, children who were children during the start of the continuous coverage have moved out of the children's category into other categories. In other words, in terms of the adults with disabilities, I need to do a little bit more on that and some analytics. We've been focusing on mental health and children in terms of trying to better understand what's going on there. But I think that, in terms of what I get for like phone calls to help people on, there's been very little in the waiver areas other than in CFI that I've taken phone calls on and, try to help people. But I can try to get a little bit more information for you there. I think the other thing that we're also seeing is potentially some lag in catching up with some determinations in the disability unit because we've had a change in contractor in terms of doing some of that work. But I'd like to come back to you with something more specific than
That
that.
would be great. On different topic, with the CFI, with the rate increases, I know we can't require the agencies to pass through the money, but what kind of reporting has the department gotten from the organizations that get the CFI contracts in terms of how much they've been able to increase compensation for the direct service providers?
I have two-part answer. The first part actually is in regulations that were published on Monday. CMS is implementing an 80% requirement of the rate to go, and I have to look more into the regulation in terms of the timing of that. I do know anecdotally, like Waypoint gave us some statistics on how much they've improved salaries, and trying to think of the other agency. Name's escaping me for the moment, but they gave like a $5 raise to their staff, and they actually, because of the spending plan money that was available through ARPA, they actually, in anticipation, actually were early in terms of implementing their salary increases. But we do get some reporting on that. I don't get that directly, but the department does, and I can bring that one back too for some follow-up. Part of their spending plan is, yep.
Representative Merchant.
Thank you, Mr. Chair. In regards to the CFI waiver, is there some numbers that look at how much we provide to the agency per waiver compared to the cost to be per day inside of a nursing home?
Yes, there is, and I wished I could remember today what the exact numbers are, but as part of our waiver proposal, we sort of put that out. I think the savings is probably, rather than just guess here, I think it's a pretty significant savings over, and if someone here remembers that number, but
That's okay, Ms. Limit.
I
Just, thank you.
back to you on that one.
Representative McDonald.
Thank you, Mr. Chairman, and thank you, Mr. Lippman. On page 9, and I think I've touched on this before, but I thought hopefully it's a different question than before. Total closure by reasons failed to read is number 2, failed to redetermine benefits. I know when I was in the department, a caseworker, and this might not be a question for you, but a caseworker had some discretion if someone was elderly in a nursing home, for example. It tended to be an annual readie because their circumstances weren't likely to change. But a younger person working, possibly changing jobs, having another child, they were on like a 6-month cycle or maybe even less, depending on, different time frames and factors. Do you know if that's still the case?
So we have, again, in part for the first round of redeterminations, we put the nursing homes and the facilities towards the back because we knew that there's more that people had to get ready for to get through that process. Like they have to get bank statement and life insurance policy values sometimes and things like that. We also it added 30 days onto the time that they had to, usually it was 30 days after responded. We used a temporary authority to increase that to 60 days so that people had more time to react to that in the waiver populations. In the CFI area, they're also using a concept called bridging to try to give people more time to respond or to get things done. It'll be interesting to see how these authorities they run through the end of 2024. What the impact of when some of that is backed off. But I think we've learned a lot by going through this, and we do a lot more in terms of noticing and outreach than probably the time you were in the department, even the time since I began in the department. That we've used the color letters, the pink letter to give people heads up, the yellow letter to warn them, and then if they close, we use a blue letter to say if it's blue, it's not too late to renew. We're sharing lists with the nursing facilities. We're looking at other options for trying to provide information for those people who are being paid that want to make sure that the people who can be eligible get eligible, like working with different groups, and we're trying to create more transparency so that the organizations can help themselves in helping the person. And some of those things are still works in progress, but I think we're doing a lot more to try to help people stay covered.
Okay.
Follow up.
So is there an average redetermination period? Like, is it, if not 6 months, is it like 8 or 9 or?
So we're, in terms of someone is required to be annually redetermined under normal circumstances, or if there's a change in circumstances. There's also, if someone is also receiving SNAP and Medicaid benefits, they can be redetermined on a 6-month basis. Okay. if it's to their benefit in the Medicaid.
Okay, great. Thank you.
See, no further questions.
I did want to, if I could, Mr. Chairman, there was a question about the certification of community health workers. Is when we talk certification under Medicaid, we're really talking about someone who is under New Hampshire law, credentialed through, licensed or certified through OPLC, and that's what level they need to be able to bill Medicaid. If you want to hear about dental, we can do that.
I always want to hear about dental. In fact, I have a dental appointment this afternoon. I will give them your regards.
I hope you get a gold star.
I don't want a gold tooth, but I'll take a gold star. Thank you. I used to want stickers in my previous committee, but that's another story.
Well, good morning, and thank you for allowing me a few minutes to just bring you up to speed on adult dental. We were very excited to celebrate our first anniversary on April 1st. I can't believe that a year has passed already. And I just want to extend my thanks once again for all of the support and interest in the adult dental benefit. We wouldn't be here without legislative support, so thank you. The first part of our report has to do with service utilization and program administration. I think you can see that from implementation in April of 23 coming up to March of 24. We've had a steady increase in the number of unique members being served every month and the number of claims being submitted. With a few little waverings, December and January were a little bit dicey. There were some weather issues and then holidays. So that is not an unexpected drop in those numbers. But you can see that February and March came back very strong. So these claim totals were produced the first or second week of April, and we were just short of 3,500 claims and slightly greater than 2,500 unique members served in the month of March 2024. We have served over 12,000 unique members to this point, and I would say that that number also is increasing on a monthly basis. The next page gets into our network dashboard, which is hot off the press 2 days ago. We're now up to 165 providers. That includes oral surgeons. We also were very happy to add a prosthodontist in the last couple of months. And in ongoing efforts of Northeast Delta and DentaQuest, they have had over 60 office recruitment visits since January 1st. And those recruitment visits include not only reaching out to dentists who are not yet enrolled in the program, but coming back around to the folks that enrolled early in the spring last year and checking in with them to see how things are going. How is the benefit working for you? How is it working for the members that they serve? And what has their experience been? And also, most importantly, if they're at a point where they could potentially take on a greater load of members. So, those efforts are ongoing. When you look at the county breakdown, Cheshire is the county with the least providers at this point. When we move to the next page and start talking about mobile services, you will see that we are in the throes of getting that first date nailed down for Cheshire to do a mobile clinic. And then the two areas, Sullivan and Carroll County, have yellow arrows, and those are now in regular rotation with the mobile services. And in particular, in Sullivan County, we're working on an additional location so that we can increase the footprint there. And this planning, I will tell you, is ongoing. When you look at the schedule today that I present to you for mobile services, it's much more robust than 3 months ago or 4 months ago. And to that end, on April 11th, we met with Northeast Delta and DentaQuest and Solvair, who actually does the mobile services, to really strategize what does the mobile service portion of this network look like for the longer term. Initially, we thought that that was going to be a temporary measure, and we realize now that just because of workforce issues and shortage areas for providers, we're going to have to keep using the mobile services and really have them become a stable portion of our network where our members can go for recurring visits. And then in terms of stakeholder engagement, I do want you to know that probably the only meetings that we have curtailed at this point are those for the technical implementation, because at this point we have all our systems in place that move the data back and forth between the state and the two dental organizations, Northeast Delta and DentaQuest. But all of our other meetings are still going full tilt, just as they were a year ago. We are not sitting back and saying, okay, you have the program, this is it. We realize there are areas that we need to strengthen. So the New Hampshire Oral Health Coalition has been key in our activities. They very graciously held the birthday party for legislators that was held on March 28th, and I hope that some of you were able to be there and have some birthday cake. Again, that was to show our thanks for your support and the work that everyone did to get us to the point of finally launching this benefit. The coalition is also hosting a summit on May 9th, which basically will be an opportunity for stakeholders and public members to come in and talk about what happened over the last few years that led up to the benefit, how the first year has gone, and then to have some open discussion about what do the next few years look like with the benefit. It's very important to us that we have input from the public. We need to know where things are working well, where we have areas that we need to work. And so I have to say that Northeast Delta Dental, as well as DentaQuest, have been very good partners in this venture. And they are committed to making sure that we develop all of the parts of the benefit that we need so that we can serve all of the members. So I don't know if you have any questions at this point.
Representative Weber.
Thank you. Thank you for all this work, and it's great to have gotten this far. Do you have a location for Cheshire County set?
I
Or
don't
is-
know. I don't know
or is
the
it the
location.
schedule? Okay.
Salver is doing that, and I'm sorry that I don't have
That's
the
okay.
actual
I was just-
address.
Just curious. If it becomes a problem, if somebody could give me a call or shoot me an email, I can with the requirements, I'd be glad to try and
Okay.
help find somewhere.
Thank you very much. I appreciate that.
Senator Rosenwald.
Thank you. Thank you for your work on this. On the slightly different question of children, as you know, I went to visit this public health school-based program where the care is delivered by hygienists. Is the department working, or will the department be trying to include coverage under Medicaid for that silver diamond treatment and the temporary restorations
Yes,
as
that is
delivered in
something that
schools?
we are working on right now. The basic services of cleanings and regular fluoride varnish and sealants have always been covered in those locations, and we are working to expand to the other fluoride and the temporary restorations.
Could you give me an update, please, on one of my perennial questions on loan forgiveness to current dental students who will make a commitment and to relatively new dentists who are out in the field who would like to make a commitment for loan forgiveness?
There are actually two programs. There is the state loan repayment program, and we actively are advertising the fact that that loan program is available. Messaging goes up on the state's social media sites from time to time. I share that information with the Dental Society to put out. I also include that information for the offices that I have to survey for the children's benefit. And now I'm happy to add that the Northeast Delta Dental has made a very sizable commitment to loan repayment over the tri-state area. They serve Maine, Vermont, and New Hampshire. And I have been able to sit on a steering committee for that loan repayment program to help guide them, because like the state program, there is a requirement for those individuals to treat Medicaid members. So we actually are having a meeting June 3rd where we will bring together folks from Northeast Delta as well as the state to talk about where we are right now today with both loan repayment programs and what does the future look for that, for us to work together to make sure that dentists are recruited to the state and are aware that those two programs are available.
At some point, could you send me a one-pager, maybe send it to the whole committee, and anyone who wishes to look at it will have an opportunity to, please?
Absolutely.
Thank you. Any other questions? Seeing none, thank you so much.
Thank you very much.
The chair recognizes, as she approaches, Administrator Courtney Keene from the Division of Public Health Services for the Newborn Screening Annual Report, which is wisely entitled Newborn Screening Program. Thank you.
Yes. All right. Good morning, Mr. Chairman and members of the committee. My name is Courtney Keene, and I'm the administrator for the Newborn Screening Program for the Maternal and Child Health section in the Bureau of Family Health and Nutrition in the Division of Public Health Services. I have direct oversight over the Newborn Screening Program. Yes. Yep. Is that better? Yes. Great. Sorry. I am pleased to present the Newborn Screening 2022 Annual Report. RSA 132-10A requires that a physician, birthing facility, midwife, or other healthcare provider attending the birth of a newborn to screen the infant for a panel of heritable disorders. The statute also includes a clause, 132-10C, which allows parents or guardians to decline the screening if they so desire. The Newborn Screening Program is responsible for ensuring that all infants who are born in New Hampshire are screened for 36 heritable conditions. This is specific to New Hampshire. The conditions that New Hampshire screens for are based on what the Recommended Uniform Screening Panel, also known as the RUSP, have approved. The Newborn Screening Advisory Committee votes on approving or denying additions to the New Hampshire Newborn Screening Panel based on the following criteria. The disorder is well defined with a known incidence. The disorder is associated with significant morbidity or mortality. The disorder can be detected with a screening test that is ethical, safe, accurate, and cost-effective. Effective treatment exists for the disorder, and that early treatment, meaning before the onset of symptoms, is more effective in improving health outcomes than later. The program is also responsible for ensuring that screening is done in a timely manner, and any presumptive positive or out-of-range result is reported to a provider. The goal of newborn screening is early identification and treatment if needed. The program is reporting 2022 data due to the length of time it takes to receive a confirmation of a disorder. It takes about a year to confirm a disorder. In calendar year 2022, there was 12,135 births, with 99% of them being screened. Of the infants who were screened, there were 732 infants who had an abnormal or presumptive positive screen. Of those, 30 had a confirmed heritable condition. 2022 was a year of staff transitions at the department. The program went from 1 FTE to 2.5 FTE, which brought the program to staffing capacity. The positions are supported by the revolving funds and a federal grant. The program consists of a nurse consultant, a follow-up specialist, and a quality improvement specialist. Each position has a unique role in making sure that infants are screened within 24 to 48 hours of life and followed up if they have an abnormal or presumptive positive screen. The program relies on timeliness of specimen for optimal results. The program focused on 2 quality improvement activities: improving timeliness and decreasing unsatisfactory specimen. The first quality improvement activity was timeliness of specimen, being shipped to the contracted laboratory, the University of Massachusetts Chan Medical School. The program worked with each birth facility to confirm pickup of specimen by either UPS or City Express. By streamlining this process at each birth facility, it has reduced any potential delays by the courier. Each birth facility is provided a quarterly timeliness report, which focuses on measures within the control of the hospital staff, which means drawn between 24 and 48 hours of life. Historical data demonstrates significant progress since 2015 meeting the target of 95% of specimen being collected within that 24 to 48 hours. Please refer to Appendix B of the report. The program also worked with birth facilities to decrease the number of unsatisfactory specimen. Unsatisfactory specimen are poor soaks, contaminated, drawn prior to 24 hours of age, improperly dried, and clotted. Any unsatisfactory specimen requires a repeat test. The infant must return to a facility where staff have the expertise to draw the specimen. Most infants go back to their birth facility, however, some go to their PCP. A repeat test also incurs additional costs to the facility. From January to December of 2022, birth facilities spent $30,368 on repeat specimen. This includes repeats due to abnormal results and unsatisfactory specimen. By working with birth facilities to reduce the unsatisfactory repeat specimen, the program saw a 2,628 decrease compared to 2021. The program continues to collaborate with the birth facilities to keep reducing the numbers of unsatisfactory specimen, thus reducing the cost. The future of newborn screening. Newborn screening remains a dynamic field. Advances in science and technology are ongoing and continue to impact the newborn screening program. The program will continue to monitor data quality and provide unsatisfactory specimen and timeliness reports to all birth facilities in the state. In the coming year, the program will maximize the use of data and quality improvement recommendations to ensure no infant is missed, excluding those who declined. And all other infant specimens are tested and followed up on in a timely manner. The program applied for the United States Health Resources and Service Administration State Newborn Screening System Priorities Program, and it was awarded the grant. The grant supports screening programs to address state-specific challenges and implement new quality improvement activities, such as improving and expanding the newborn screening management information system, implementing screening for new conditions added to the recommended uniform screening panel, or the RUSP, and increasing access to treatment and follow-up for individuals and families identified with a heritable condition through the newborn screening program. I want to thank you for this opportunity to present the 2022 annual report. I'd be happy to answer any questions you might have.
Ms. Keene, on page 9, this wonderful little chart here, I would assume on towns on the border, people in Plastow might go, God help them, to Stewart Hospital in Haverhill or a little further west to Lawrence or something. Is there any way that we get that data?
No. So this is only babies born in New Hampshire.
Okay. Second question, is there an increase in out-of-hospital births because of distance or because I noticed Parkland and Derry is not on this list, so you're in Derry and I'm just plotting, oh my gosh, get in the car quick, and whoops, we didn't make it. Do you see A, an increase, and B, should that take place, would it be fair to assume then somebody continues the trip into the hospital where the test is made?
So there was a slight increase in out of hospital births. Midwives, this is midwives too. So midwives have these filter papers that they use and draw the sample on the infants.
Good. Well, thank you. Representative Murphy.
Thank you, Mr. Chairman. I have a few questions. One of the questions we talked about previously, you have 99% get screened.
Yeah.
And I'm assuming based on the chart on 6, that is a blood test that's done because there was clotting and there was insufficient blood noted. Are any of the screenings done currently that involve, urine or saliva?
No. This report is specific to the blood.
Only the blood?
Yes,
So the 99%, all of them are basically blood tests.
correct.
Are these blood tests taken from the baby, the infant when born, or are they placental blood removed, or this is from the baby itself?
Yep. So there's it's a paper that's about this big. And it has 4 circles at the bottom of it, and it's taken from the infant's heel. So after 24 hours of life, blood is taken from the infant to test for our conditions.
So this is a heel stick, what you're talking about then?
Yes.
Okay. And so I'm assuming then that, to any other tests that would require saliva or urine would be an increased cost?
It would be.
Okay, thank you.
Representative McDonald.
Thank you, Mr. Chairman, and thank you for taking my question. I'm going to show my ignorance, of which I have an abundance. Heritable, does that mean inherited? Oh, okay.
Yes.
I kind of assumed so. I've just never heard that term before. If I may have a follow-up?
Follow-up.
Getting back to the chairman's question about, like, Parkland isn't on this list on page 9. I know Franklin has a hospital that's not on this list. Various hospitals aren't on this list. Could you explain why that's the case? Do they not do this, or?
So they have to have a maternity or labor and delivery unit
Okay.
to do this test. However, hospitals that don't have a facility still have the test. So if a baby comes into the emergency room at Franklin and delivers, the hospital has one of these papers to do the test on the child.
Okay, but that's not a tribute, excuse me, did I have one?
Yeah,
other-
yeah, right.
But if the baby is born there and they have to do the paper, but it's not recorded as Franklin having done it, or?
Yes,
Okay, but it just hasn't happened there.
correct.
Okay.
It's very infrequent that we have a hospital conduct a filter paper on, they're called filter papers, on a baby that does not have a labor and delivery or maternity unit.
Thank you.
Would the assumption be the reason not all hospitals are here could be they're very, very small and it's very expensive to maintain this unit, or they are for-profit facilities and do not see this as a good loss leader for them?
I'm actually going to defer that to Trisha Tilley.
Hi, good morning again. So thank you. This is a great report. And I think you all are asking the right questions around access to labor and delivery services in the state of New Hampshire. I often show, and my colleague Henry does as well, there's a map of New Hampshire sort of right across the middle of the state. In some ways, it's Route 11 from Claremont over to Rochester. We have lost all our birthing facilities there. We've also lost facilities in the southern part of the state, as you notice with Parkland. And so this is all a place where you're seeing potentially increased numbers of out-of-hospital births, as the question that you asked. Sometimes we see people move to midwife facilities. Sometimes that's in the home. Sometimes there are some birthing facilities run by midwives there. The reason for those facilities to close are multifactorial. Often it is because there are small numbers. Workforce is really the biggest thing that drives it. In order to have 24-hour coverage to deliver babies is really expensive, especially for those small hospitals. So that's why we've seen many of those critical access hospitals close down. And then, of course, the for-profit hospitals have their own rationalization for the services that they choose to provide.
Yeah. Senator Rosenwald.
Thank you. We've heard anecdotally that some women are choosing home birth because they can't afford the copay, or the coinsurance, the out-of-pocket costs for either a hospital or a freestanding birthing center. And I'm sure you guys have heard those reports too. But while that's concerning to me, my question is, a home birth, that would that require the attempt to do the newborn screening as well?
Yes.
No matter who attended?
Yep.
Even if it was just your best friend?
Yep.
Thank you. Because they would know about it.
They can opt out, though, as well.
Well,
So-
they can, but somehow if your friend was attending your birth, they would somehow know they were required to do newborn screening?
Yeah, so that's a tricky question. Most at-home births have some type of midwife following them for their care. I don't know, and maybe you do, of any person who's not had any prenatal care and then delivers at home. But if a midwife is part of the process, they have one of these filter papers that they would offer to the family, and the family can decline if they would like to. So yes, so someone, my best friend could deliver, but the midwife would be there to support and offer this screening to this family.
Representative Merchant.
Thank you, Mr. Chair. With the evolution of at-home births or births not inside of the hospital, is it possible in this chart, not for this time, maybe for the future, to include a line in here for at-home births that we can look at that point in time as percentage
Are you referring to the one on the last
on
page?
on last page, page 9?
Yes, we are currently in the works of that. It just hasn't been done for 2022 data. So the next report will include out of state or out of hospital births.
Follow up
Mr.
on
Chair.
next question.
And also when that report, this is very insightful, is looking at just the percentage, but looking at overall births, if you will, within a facility, because what I'm trying to understand is that if we're seeing that go down consistently, so we look at the Claremont to Rochester, that band in the middle, if we're starting to see a decrease in births inside of a hospital, it's probably economically, they may be vulnerable to closure. So is there any way to get a trend in numbers of what's happening, not just a percentage, which is what you're dealing with here, but looking at the number of births being done within a facility over a period of time? Because if it's trending down drastically, that's probably not a good thing in some ways.
Can I ask a clarifying question? Would you like to see the number of infants born at each hospital? Is that your question? So like in that region?
Yes, because what I'm trying to get to is in certain parts of the state, particularly in the rural parts of the state, if we're seeing that go down dramatically for whatever reason, it's probably an indication that something's happening. It could be because of the number of residents in the area itself, which is natural. It could be because of other economic issues going on.
Yeah,
I was just going to say, we are tracking that data. It is, we're working closely with Medicaid and public health together to understand those dynamics, especially in those rural areas around where people are getting their care. Also, we're also tracking that, for example, in Sullivan County, are you going up to Dartmouth? Are you going down to Cheshire? Those are all part of the data that we're following.
But we can put that in the report.
Any further questions? Thank you so much.
Thank you.
The chair recognizes Danielle Hernandez, Administrator, Division of Public Health Services, State Office of Rural Health.
Good morning, Chairman Pearson and members of the committee. Danielle Hernandez. I am the administrator of the Health Professions Data Center, or HPDC, that sits alongside the State Office of Rural Health under Rural Health and Primary Care section in the Division of Public Health Services. That is a mouthful, and it never gets easier.
How many business cards does it take?
I have to cut some of them out there. It is my pleasure to be presenting highlights of the 2023 report on the New Hampshire healthcare workforce and data collection. You did receive the full report electronically at the beginning of the week, but you should have in front of you the executive summary and some data tables to follow along with this presentation. Okay. So, all right. Everybody's set. So the State Office of Rural Health is statutorily required to receive available data and collect data through provider surveying during the license renewal cycles to assess the current and anticipated supply of primary care providers in the state. The data is immensely valuable, right? It supports and it strengthens federal shortage designation, which our office coordinates, and that brings providers and grant funding to medically underserved areas of the state. It supports recruitment and retention initiatives, among others, the State Loan Repayment Program, National Health Service Corps. It supports the development of new and expansion of existing educational and training programs, most recently Coos County Family Medicine Residency in Berlin and Cheshire Family Medicine Residency in Keene, and of course, emergency preparedness. HPDC is the only entity in the state that exists as a central repository for advanced practice healthcare workforce data and maintains a level of detail necessary for accurate medical, behavioral health, and oral health workforce estimates. As such, data requests continue to increase each year from our partners in higher education, provider associations, health policy and practice organizations, and of course, CHHS public health programs to inform their grants, workforce initiative strategies, and internal reports. In addition to these annual reports, HPDC releases annual provider workforce data reports that can be found on the rural health and primary care web pages, and those links are provided for you under the introduction section and the executive summary. These visual data reports have dashboards on survey response rates, practice status, demographics, education and training, practice capacity, distribution, patient access indicators, anticipated supply, and workforce differences by rurality. Okay, so I'm going to move on here to page 1. All right, so table 1 on page 1 shows license types included in this year's report for medical providers and behavioral health providers and the data collection period. So the report reflects data collected in 2021 as our turnaround period for reporting is 2 years after the data is collected. Some providers, you'll notice, do have 2-year combined data. That's to ensure reliable statistics because of for mental health practitioners and psychologists, there's a maldistribution of providers by license renewal year. And then for others like ADACs or alcohol and drug counselors in the state, there's just a low number of providers. So combining that 2-year data gives us more stable statistics there. Table 2 shows survey response rates for state fiscal year 2021. And you can compare the 2021 rates to the 2020 rates in the column right next to it for notable changes. We can see here that there are significant increases in compliance with APRNs in the first row and mental health practitioners. That's likely a result of the board rules being promulgated in state fiscal year 2020 and the boards having more of a direct hand in compliance follow-up. And please feel free to stop me and interrupt me if you have any questions. Okay.
Representative Weber.
Yes.
I just had one preliminary one.
Yes.
What's the reason for the 2-year lag in the data?
It takes a long time to clean and organize and report, visualize the data. It's really because our staff capacity within the program is me as sort of the epi as well as the administrator. And then we just hired in this last year a data analyst programmer to try to speed things along, but it's a steep learning curve. We're hoping to have turnaround time about a year after. We're not there yet.
Is that because the data is reported in all kinds of different formats from all kinds of different people?
Not in different formats. We maintain the survey tool within the program, but the license renewal cycles differ. I know that OPLC has changed that as of, February, I think, of 2023. They're starting to move to rolling renewals. But with this data, before then, it was that APRNs and mental health practitioners were just on rolling cycles, while others like PAs were October to December, ADACs were April to June. So it sort of is scattered. You're welcome. Okay. The average response rate across provider types is 90%, right, which is great. We're hoping to maintain or increase that rate for reliable representative data with continued compliance enforcement by OPLC. Now, completion of the opt-out form does meet the licensure requirement. We love to see that it's remained low, though, since implementation. It remains at about 1% to 2%. And it's great because the rich survey collected from the survey tool really does allow for those in-depth specialty analyses for comprehensive workforce assessment. Okay. Okay. So Page two contains supply changes according to the license list figures maintained by OPLC. So the net change percent, that's all the way to the right, demonstrates no true loss of providers during state fiscal year 2021. We see that psychologists broke about even, minimal increases for physicians and ADACs, and then some saw significant gains, especially for APRNs, where we see workforce gains nearing 25% and PAs at 20%. Now, I'm sure you're all thinking this, but the increases likely do come in part as a result of several executive orders issued during the New Hampshire COVID-19 state of emergency that eased barriers to licensure and clinical practice. So unsurprisingly, right, we see this influx of APRNs and PAs that have very similar scopes of practice as physicians, right? They can work in a variety of settings and they can practice largely independently. What's not clear with the licensing list figures is whether these new providers are practicing at the top of their license or whether they're just aiding in pandemic efforts. So we'll just continue to analyze this data, see how future years compare. I have a guess, but we'll see that shake out as we go on. All righty. Page 3 here, I'm just going to highlight a few interesting workforce statistics for medical providers. There's much more in the full report, but these few sort of stuck out to me. So Table 4.1 has the percentage of clinically active providers across medical provider types. That's those providers who have an active status license that are clinically practicing in New Hampshire. We can see about 3/4 of APRNs are doing that, over 90% of PAs, but the physician rate is just over 60%, considerably less. And that's a rate we see consistent year to year. I love to point this out at every opportunity because it really shows value for this program. If we were only to use the licensure list to estimate supply, we would be grossly overestimating the supply of physicians in this state. Table 4.2 shows the percentage of primary care providers of those clinically active in New Hampshire. Physicians and APRNs are about 20% of those clinically active are in primary care practice, 16% of PAs. There is no national benchmark here, but this percentage does fall short of the recommended 40% of active providers in primary care by the National Council on Graduate Medical Education. Table 4.4 summarizes anticipated supply indicators, which obviously helps to paint the picture of future healthcare supply in the state. So the first couple, provider age, this helps to inform anticipated supply where younger providers can offset workforce shortages that come from provider retirement. We can see that for primary care APRNs, about 1/3 of them are under 40 years old. This is about 2 times higher than those 60 years and older. For PAs, we see an even greater gap that 45% are under 40, and that's 3.5 times those that are 60 years or older. However, we see the very opposite is true for physicians, where about 1/3 are 60 years and older, and this is about 2.5 times those that are under 40 years old. The anticipated practice figures for primary care physicians also a bit discouraging here. We see about 1/3 of primary care physicians anticipate a reduction in practice in the next 5 years. Of those, about 20% plan to not practice in New Hampshire at all. So that's either by practicing in another state or just ceasing clinical practice altogether. I will say that these statistics, it's not on the chart, but I like to, add some of the comparisons that I can from the previous year. These statistics are a bit worse than what we saw in 2020 data. So that suggests, right, that these indicators were likely impacted by the pandemic. So we'll see if this changes in future years. Oh, actually, I want to add just one more thought or a couple of thoughts to this bleak picture that I painted for physician supply in the state. We do see, right, this big picture that we can expect a continued decrease in physician supply. However, a key practice measure that could offset this is in-state training, in-state residency. We have 3 family medicine residencies currently in the state. We have 2 under development in rural areas. That's Coas Family and Cheshire Family Medicine residencies. We can expect the primary care physician to increase supply, to increase with increased access to in-state training. The other consideration here is with respect to supply gains, education trends, and retention indicators that we saw here. It's possible that APRNs could also counterbalance this future physician loss.
While you're on that subject,
Yes.
could you tell me where the 3 family practice residencies in New Hampshire are located?
Yes. One is at Dartmouth Hitchcock Medical Center, right? Yes, one is at the Concord Hospital. It is connected to Dartmouth Hitchcock at Concord Hospital, and the other is the Portsmouth Regional Hospital.
Thank you.
I believe that. Yes, those are still, yes, just starting up. Yes.
Mr. Chairman?
Thank you. Yes, go ahead, Doctor.
Do you have that broken down as to where these anticipated reduction in practice in 5 years are located? Meaning that, is it worse in the North Country, the western side of the state, or southern part of the state, or where is it most? Where are we going to feel that impact most?
We do. We are going to move actually to that breakdown, not by public health region, not by town level, not by county level. We do see, well, we do break it down by rurality, so rural versus non-rural. In previous years, we did see that there was a discrepancy there, that there were higher rates of anticipated reduction in practice in rural areas. We don't see that with this data, we're guessing because of the pandemic and provider burnout. So it's because of a spike in non-rural rates is why we're no longer seeing that discrepancy.
A question for either one of you. Is the medical school at Dartmouth holding steady with the number of places, or is it increasing?
I haven't heard of additional seats being added to the program, but
I don't know that it's increased at all, but it is relatively new, as is the Cheshire one.
Okay. No, I mean at the med school. You want to go be an MD.
Oh. How many are graduating and going into primary care?
No. Is the number graduating constant, or are they increasing the spots there?
I believe that number has stayed fairly stable.
Okay.
But the
Yes.
number of people going into primary care has dropped off precipitously.
University of New England in Biddeford, Maine is increasing its number of spots, and we know osteopaths tend to prefer primary care at a much larger rate than MDs.
Right.
So there is some help there, and especially with Portsmouth's residency.
right. And I believe there's also opportunity through UNE to have some clinical rotations in rural parts of the state through their program.
Well, we're not rural in Kingston, although we don't have very many people there, but we do take such rotations at the facility I'm part-time CEO of, so there's hope.
Yes.
Thank you.
Okay, so looking at table 4.5 on page 4. This is the breakdown of practice by geography and clinical practice. So we see across all provider types, about a third of practice is in rural, with primary care practice representing only a fraction of total practice, especially for PAs, where we see primary care practice extremely limited, just at 3%. It makes it so that we can't really get those filters on there to dive into the data for PAs. as we can for APRNs and physicians. The figures 1 and 2 right under that table come as a new analysis to this report, showing primary care practice distribution by public health region and as a proportion of total practice. Overall practice, it should be represented by a blue bar. I believe it's black because our copier only prints in black and white. And outpatient primary care practice as a proportion of total practice should be in orange. I believe it's in gray. And we see with this that while overall practice is more variable across the state, right, we see high amounts of practice in Upper Valley and Figure 1 for the rural public health regions, and also very high in Greater Manchester in Figure 2 with the non-rural public health regions. But what we see for primary care practice is it's more consistent across the state, especially in non-rural New Hampshire. All right. So page 5, tables 5.1 through 5.3 show significant differences in provider and practice characteristics by rurality. So all of these characteristics here aren't those that were tested, it's those that were found to be statistically different between rural and non-rural areas of the state. Some interesting changes not on there, but that I want to point out again from 2020 analysis to point out just because it's likely pandemic related is that there's no longer, as I said, a difference in anticipated reduction of practice between rural and non-rural areas because of the spike in non-rural rates. The other difference is that, or other change is that there's no longer a difference in the rates of IMGs or international medical graduates between rural and non-rural because of a spike, again, in non-rural rates. A new trend we see across all three provider types is a higher rate of newly trained providers in rural compared to non-rural, according to the indicators graduation within the last 10 years for all three types, and then practice in New Hampshire for under 5 years for APRNs and PAs. We'll see again, right, if this trend continues or if it's an artifact of the pandemic. I would be remiss if I didn't point out two characteristics in rural that sort of go along with that idea I said earlier about really the importance of, training and pipeline for our providers. It's that rural physicians are more likely to have graduated from a New Hampshire medical school and to have trained in a residency within the state. These findings we see consistent year to year. And it is important, right? Because it tells us that if we want greater access to healthcare in rural, we need to support the education and training efforts.
Representative Merchant.
Thank you, Mr. Chair. And thank you for taking the question.
You're welcome.
If one of the key factors is graduating from a medical school in New Hampshire, is there any thoughts of working with the University of New Hampshire to create a medical school? I mean, I'm not trying to take away from Dartmouth, but if we have a growing need, and one of the factors is where they graduate from, is there any discussion going on about trying to find a way to develop a medical school or osteopathic school, either one, in New Hampshire itself, with UNH being sort of the base?
I haven't heard those discussions. I will say, obviously apart from physicians and speaking about another advanced practice type, APRNs, UNH does have a grant called a new Advanced Nursing Education Workforce program where they are training APRNs specifically to work in rural areas and medically underserved areas of the state. So I do know that initiative is ongoing with a federal grant. I haven't heard those discussions, but certainly it's worth bringing up at one of the upcoming commission meetings on the interdisciplinary primary care workforce. Thank you.
Senator Rosenwald and I are over here plotting and some things. So, yeah.
Yes. Well, that's why this report is so important to bring this to policymakers' attention. You all are the ones that really affect the change. So, and we're always happy to have you at that Primary Care Commission meeting.
Any further questions? You're waving at each other. Representative, whoever has the question. You don't.
Thank you.
We were told from the floor the other day that if women just had more babies, obstetricians would come.
Anyway, any other questions? Because we have exactly 2 minutes left.
All right, we've made it to the last page. I'm hoping to get through this one because this is another exciting new analysis that we added to this report and plan to continue to keep it in this report moving forward. This is the primary care provider rate per population. We can see here in table 6.1 that rates are highest for physicians at 54 primary care FTE providers per 100,000 resident population. But if we look at the supply by licenses in the state at the bottom of the page here, we can see there's many more physicians licensed in the state at 8,500 than there are APRNs. You know, there's twice the number of as there are APRNs, and especially PAs. So with this in mind, the rate of, 30 providers per resident population for APRNs is relatively high when taking supply into consideration. The combined outpatient primary care rate is about 94. That's the last row in the first table. That translates to one primary care provider for every 1,066 people. Now, sort of as I had said with the percentage of primary care providers relative to all active providers in the state, there's no hard and fast benchmark for this, but WHO estimates that at least 2.5 primary care providers per 1,000 people are needed for adequate primary care coverage. And that's 1.5 times as many as we have statewide, according to this analysis.
What was that number again?
Which one?
2.5.
Oh, yes. Looking at table 6.2, this ranks the public health regions by rate. So we can see actually the top 3 rates are all in rural. Upper Valley's number 1. This should really come as no surprise. Dartmouth-Hitchcock Medical Center sits in Upper Valley. It also has a very low resident population, which you can see in the right-hand column here. However, the next 2, North Country and Carroll County, we see as demonstrated successes of the benefit of shortage designation and the grant opportunities and the funding that follow to strengthen workforce initiatives in primary care in these areas. And that's all I have. I made it in 20 minutes. Are there any additional questions?
Good, thank you for your report.
You're very welcome.
I have the tentative agenda for the next month's meeting, which is slated for Friday, May 24th. Now, the Monday is Memorial Day. I don't know if that will pose a problem to anyone. I'm around, but do we want to try to move that, or? I'm okay with it.
Okay with it.
Okay?
I'm going to hand out my business card just because we're
Well-
always happy to fulfill ad hoc data requests or answer any survey tool related questions.
Okay, one for you and
Thank you.
one for me. Thank you. So it looks like our next meeting will be Friday, May 24th, 2024. Thanks, everybody, for coming. We're adjourned. following what's going on in Massachusetts with the Stewart Health System. It is in bankruptcy. And it's a for-profit hospital, and they don't have enough money to pay their vendors, but their CEO just bought a $40 million yacht. I would not be opposed to sending to hospitals. You have to be nonprofit. because
Parkland's profit. Parkland's for profit.
I believe it is private for-profit. And if you want to have a board of directors and be run well, then I could support some state funds to open in hospitals.
Many hospitals.
Oh, I've done that, not a problem.
You've only got 36 hospitals or something.
I think we have fewer than that.
Lucy, do you know how many hospitals we actually have in New Hampshire?
It's 20-something.